So I just realized I've been introduced. Thank you. Yeah, we were having a wonderful conversation. Welcome to the session. I assume our slides will be starting out. Eventually we'll get to me reading from the actual promises that we've made when we set out to do this session. But let me introduce very quickly my panelists. So this is Kat who is the global head of strategy at operations at Johnson & Johnson. Then we have David, who is the global head of drug development, cardiovascular, and metabolic diseases at Novartis. And then next to him is Patrick, who is the VP of Marketing and Health Education at the American Heart Association. And on the end, we have Swapnil, who is the Executive Director, Center for Observational and Real-World Evidence Core at Merck. And then of course I'm Fred Trotter, and I'm the CTO at CareSet. And let me first admit that, in fact, we were literally just talking about this. It's very hard to have titles like this and then compete against Game of Thrones and the other wonderful things that are happening here at South by Southwest. So thank you so much for being here. We will absolutely live up to our titles and provide you with some in-depth content, but also some things that are I hope, kind of interesting, hard questions about the healthcare system. So could we pull up the panel description real quick? I apologize, I'm to the people running the slides, I am doing this out of order. All right, so this is what we wrote. And I've bolded and highlighted a couple of things that I wanted to emphasize about our session here. Reducing unnecessary procedures and reducing the invasiveness of those procedures that are done, and detecting things earlier so that when you are fixing something, you're dealing with a less severe problem. And then in general, what that puts you in a position to do is to steal money from a cost in the future. And of course, if you're, we don't have any healthcare plan people or people from CMS on the panel, but if you're concerned about how you pay for these new innovations, it is a problem because you're increasing costs sometimes substantially in the current year, but what you're doing is stealing future costs that are much higher and much more expensive, and you're dramatically improving the person's life because instead of having a month in the ICU before they die in 5 years, you're giving them 10 years of life or 15 years of life. So the impacts on people's lives are very significant, and the impact on overall cost is actually positive as well, even though you are increasing costs in the short term. So you have these, but having said that, of course, increased costs at all are a problem for our healthcare system. Healthcare is already too expensive, and these things are extremely difficult. And if you put these things together, you're faced with a lot of movement, a lot of change happening very quickly, even as other things change in the healthcare system, and sometimes in ways that we don't know. Obviously, politically speaking, we had a revolution with Obamacare, and who knows what Trump care is going to change. The landscape of healthcare is changing underneath us, even as we agree on the notion that we should have innovations moving forward. So with that, I always like to start panels with a discussion of something from a patient's perspective. And, Kat is famous, internet famous, which I'm familiar with being internet famous too a little bit. Being internet famous is just like being really famous, except not useful. So that's how that works out. And so Kat is internet famous for some of the things that have happened, and I really would prefer her to tell you rather than me, except for the prompt, that I'm fascinated by this notion of a check engine light. Can you explain your experience up to the point where you feel like that metaphor that you've used makes sense?
Sure, happy to. So I'm going to ask you guys to just put down your phone for 1 second and answer a couple questions. How many of you drive a car? Okay. How many of you have noticed that your car has better health care than you do? Okay. Okay. So there's something back here. So the reason that I raise that is because if you think about your car, when it comes off the assembly line, it's embedded with all these sensors that know what its specs should be. They know what the car's health should be. And therefore, they also know when it begins to deviate from what its optimal health is. And what that does is it allows the car to give you a check engine light. And now for some of us, what that does is it blinks at us or it makes noise until you take your car into the mechanic and you get it fixed. And what's really important about that also is that your car's computer system can give the mechanic all the information it needs to fix the car. And that allows the car to be repaired before it's broken down. And this will come into play when we're talking about some of the EHR topics later. But what's amazing is that we don't have that same level of information about our own health. And possibly even worse, our doctors don't have that information either. So our mechanics are better informed to fix our cars than our doctors are to fix us, which is kind of astounding. And the patient perspective, I was working on a strategy for this for Johnson & Johnson about how we could leverage this check engine-like concept to focus on switching from disease care to real health care and thinking about how you can prevent, intercept, and cure disease. And while I was in the middle of working on this, I went to the hospital because I was really short of breath, and my EKG and my echocardiogram were a little bit abnormal, and ended up being diagnosed with something called an atrial septal defect, which is a hole between the left and the right sides of your heart, which allow blood to flow the wrong way. And it makes the right side of your heart have to work harder. It makes it a little bit difficult to breathe. And what was amazing is I had been talking to doctors since I was probably about 10 years old and telling them that I had trouble when I exercised, that I had a hard time breathing. But they would listen to my lungs and they would say I was fine and they would send me home. And I've been a competitive athlete my entire life, so I was still playing sports in college, playing varsity volleyball. I ran half marathons, and yet I kept going to the doctors almost every year saying, I'm having trouble breathing, and they kept sending me home. So what's really amazing is an atrial septal defect is actually a birth defect. So I had literally had this my entire life, and the doctors didn't know until the right side of my heart got enlarged, and it was starting to cause problems. And so for me, it became very personal that I wished I'd had this check engine light. I'd wish that there had been a way that doctors had been able to know that what I was feeling was real, that there was something that genuinely was wrong with me, so we could have intervened much earlier. And so now I may well be the only person in the room who's had both non-invasive and invasive heart surgery, because the non-invasive surgery unfortunately didn't work. The hole in my heart was about the size of a large egg, so they couldn't fix it with a device. And given that your entire heart's about the size of a closed fist, that's a pretty big hole. But so they cut me open and they fixed it, and I ran another half marathon just 8 months after the surgery. So just getting there.
Well, so and of course the funny joke that we just realized that she was talking about how good it is to have invasive surgery, and she's like, I don't recommend either.
Yeah. when we talk about non-invasive heart surgery, I have to tell you, like, there are way better ways to pass your time than having non-invasive or invasive heart surgery. Just don't do it.
So I love that, and I actually like the notion of, which you would not recommend less being the criteria for procedures is actually pretty good. So David, let me move to you if you don't mind.
Well, I was going to ask a question. Actually, do you mind if I ask a
something
question?
interesting to say, that overrides me. You don't even have to ask.
So it struck me during your story that you did actually have a check engine light.
I did. Yeah.
You went to your physician how many times, and they didn't actually do the right tests to find the problem quicker.
Yeah.
So some of this is, optimizing education, optimizing physician interface with patients, and making sure that the patient voice is being listened to.
Yeah. I think it's a great comment, because one of the things we were talking about in the green room is wearables and what role do they play. And one of the things a doctor told me as I was going through all of this is that when you go to the emergency room and they ask you a whole series of questions, whatever you tell them is the amount that you exercise, they cut it in half. And however much you tell them that you drink, they double it. So, They just don't believe you. But if I had had, a sensor that was on me for all those years, they would have seen that when I was saying I was working out twice a day and I still couldn't run faster than a 10-minute mile, they might have believed me because I did know. I did have the check engine light, but
Right.
it's all about pattern recognition in medicine, and
Yes.
I didn't fit any of the patterns for what somebody with a major heart problem looked like. So,
So David, let me prompt you to kind of continue this conversation. This is actually a good time to mention David is new to Novartis. He's been in the industry for years and years and years, and he doesn't speak for Novartis. And frankly, none of the panelists are speaking here in a way that should be taken as a position of their organizations. They're saying what they think, and I want them to feel free to say what they think and not have to worry too much about that. And so, what you have said, and again, to continue that conversation, is that you're interested in using techniques with machine learning and moving the needle on public health, which of course, even that perspective is something I'd like you to distinguish between, the notion that you're using data to inform what you should do for, say, 100,000 people, and how that's different from and compatible with, this notion of a check engine light for a single person.
Right. Yeah. No, I think Kat's comments actually are a great segue to this conversation because, you can think about collection of data and wearables and so forth. The technology has just exploded, and so we're able to put a patch on a patient now, monitor a continuous electrocardiogram, measure their heart rhythm continuously, measure their breathing rate, measure their motion throughout the day. Where we as providers can get very close to patients. We can see how a patient with heart failure lives their daily life, which is a very different place than where we have been historically. The challenge is detecting the signal from the noise, right? So knowing that this huge pattern of data that you've collected over months or years for a patient actually does predict something that's important. And that's where machine learning, artificial intelligence come in, where that pattern recognition is actually better done with algorithms than it is done by humans. And we've seen that with many different approaches. And so one of the things that we're particularly interested in is applying that logic across the spectrum, whether we're trying to understand a patient's journey with their disease better, or understanding how we can measure patient-centered outcomes more effectively. So how can we deliver medicines where with endpoints, with data that actually shows that we're making an important advancement for the patient individually. So it's a combination of population health and then trying to take an individual patient's pattern as their device would show, and applying that pattern to a population and predicting something that could happen in the future, and hopefully intervening early, right? So the whole idea in drug development, especially in cardiovascular and metabolic, is to completely avoid the need for invasive or non-invasive procedures, right? Not in this particular case. You had an anatomic defect, so we can't really do anything about that. But for atherosclerosis, heart disease, heart attacks, those kinds of things, how can we be better at predicting those things where we can measure things that happen to a patient during their journey with their disease, measure how a drug is performing in those patients, and actually delivering a benefit to that patient. And that comes back to your point at the very beginning around delivering value. We're delivering long-term value and trying to intervene earlier in the disease process for these patients.
So I can't help but think, if you were managing a fleet of 10,000 cars, you would just go check all the check engine lights, right? That's what you would do. And we operate at such a disadvantage in public health side sometimes because we're literally using machine learning to try to predict, without just going and checking and looking, predict which engine lights are probably on. And it's in some senses it's a game that we artificially make harder than it needs to be.
Well, I think we would argue maybe that you actually want to intervene before the check engine light goes on, right? So before there's symptoms and more significant issues that lead to some procedure having to be done. It should actually be better. So you want to identify the patterns that lead to the check engine light, right?
So and of course I think that that public health perspective is a good segue, if you don't mind me making it to Patrick's work. Patrick works as part of the American Heart Association's efforts at science acceleration overall. And when I was discussing what that meant, he mentioned the notion of a digital Framingham. Now, how many people here understand or feel like they understand the implications of the original Framingham study to medicine? Is that something you feel comfortable with? I just want to get to the audience. All right, so we have a couple people here, so I will talk about it more than I normally would. The original Framingham Heart study is significant for multiple reasons. It's actually, I think, the place where we get the notion of type 1, type 2 people was notions that came out of Framingham studies years and years ago. It is the largest longitudinal study, I think, not only of its kind, but of any kind, and it has revolutionized our understanding of heart disease. And so when I heard, well, we'd like to do a digital Framingham, I was almost taken aback by the ambitiousness of that statement, which I think stands in great contrast to what we were just saying about the positions of weakness that we have as we think about how to check 10,000 check engine lights. So can you tell me what you meant by digital Framingham? Like, tell me what that looks like.
Yeah, and I think we're approaching in several different ways, right? So I run our Center for Health Technology and Innovation, and one of the challenges we have there is taking really the core product of the AHA, which are really the statements and guidelines themselves, and translating those into algorithms, health education content that would essentially flow into all these tools and systems and be the AHA inside, if you will, that aligns the data to a certain extent, and also the information, the check light information that people are getting, both from for the patient to interpret the data and also for doctors to interpret the information as well. And so many of these tools and resources simply don't align to the guidelines. These companies are spinning up products very quickly. They're launching into the marketplace. They're not looking too much at outcomes, and certainly not taking the approach that Dave and his team are taking. So part of what we're doing is trying to orient the AHA's brand and align it to the marketplace in a way that really makes sense. It's practical and useful to patients and consumers, and it carries a lot of weight with providers as well. And this new and massive stream of information that's coming from all these wearables and these new data points can really lead us into mapping and analyzing that data over time, right? And understanding a mountain of data and turning it into new guidelines. You think about the guidelines process itself, it's oriented around randomized clinical trials and understanding all the things that are going on, but really at a bench point of view, but not so much with the daily observational data and a lot of the non-clinical data. And so part of what we're trying to do as an organization through our Institute for Precision Medicine is to pull in genetic data, healthcare data, the daily observational, and the randomized clinical trial data into a centralized platform. And we're doing that with Amazon Web Services and a new platform for research and providing access to researchers to this data. We're also aligned around a grant program and giving access to dollars as well to tackle very specific problems, and allowing individuals to contribute their data to this institute, if you will, through a program called My Research Legacy. We've also launched an initiative we call One Brave Idea with our friends at Verily and AstraZeneca, and that has awarded a team out of Boston $75 million over several years' time to really look at ending cardiovascular disease, the ultimate primordial prevention, if you will. So it's very exciting times, and we're really taking an advanced view and embracing these new technologies and capabilities, the kind of artificial intelligence systems that Dave described, and really trying to understand how to get ahead of disease in the broadest sense, right? But also how to personalize the information and tailor solutions to the individual in a way that takes into account these different and massive number of data points. So exciting and interesting times at the AHA. Very different. It's not your father's AHA or mother's AHA. So exciting times.
Can I ask a question?
Always, again, feel free to interrupt.
We're running away with the panel here. So one of the things that I think was really amazing about the Framingham Heart Study, if I understand the history of it correctly, is that it was so instrumental in really solidifying the use of cholesterol as a marker for heart disease, ultimately. And if you think about the concept of really ultimately putting down the scalpel, so you went from what would be, near death or often death from a heart attack to an invasive surgery that allowed you to do bypass to a non-invasive surgery of putting in stents. But now to having cholesterol be used as a marker where you can have a pharmaceutical intervention which prevents you from ever needing any of the surgeries to begin with. And so if we think about ultimately fully putting down the scalpel and being not invasive at all, massive studies like that are critical for understanding what are the really early signs of heart disease, what could be the check engine light before you're feeling any symptom that could allow you to make surgery really obsolete. And that would be the holy grail, right?
I think you're exactly right. And you think about how Framingham worked, is something like 5,000 patients, and it's all mostly face-to-face, the genetic data and third generation. And now you think about what all you were talking about, this massive amount of information globally from all parts of your body. It's overwhelming, frankly, and it's really about interpretation, as you mentioned, and where you're getting that data along the health continuum, right, from early age to end of life, and then understanding how the learnings from that can be modeled back into solutions, new evidence and new guidelines, right? The normal guidelines process, the RCTs drive us to the class 1A, class 2A, and so now what we're talking about here is using this data to derive a new guidelines process, ultimately. Faster, smarter, quicker, and it really goes all the way, really think about the primordial component of this. Example is my kids in their teenage years last year came home from the pediatrician with blood work and full workups. Never seen it before. My wife throws it to me, puts it on the table. She'd throw it. Puts it on the table and said, "Here you go, smart guy." And I said, well, "What am I supposed to do with this?" And she says, "I don't know. What am I supposed to do with this?" And I finally called the doctors. No, you've seen your blood work. There's no information there. That's the classic dashboard waiting to happen, right? Is the blood work table that nobody understands except the doctors. I call the doctor and they say, look, the American Academy of Pediatrics has decided, and our chapter has adopted in Texas, that we should do blood work at the annual physicals, and here you go. And we say, well, what does it mean? My son's, cholesterol is up. They say, well, maybe. So, you have some real simple opportunities even there, let alone the things that you guys are talking about. So there's ways to get way ahead of this and to start doing some really meaningful things. Some of those things are going to be very simple, and some of them are going to be personalized medicine and new guidelines and really sophisticated. So again, I think it's a very exciting time.
So, I hate to interrupt the panel to introduce the panel. You always know you're going to have a good panel when you struggle to even get all the way to the end and introduce everybody. Swapnil, you have been working at CORE, which is a group within Merck. I don't know how close people are, but CORE has always impressed me inside Merck. All the interactions I've had with them have been really impressive. And you do work near randomized control trials. Now, again, nobody raised their hand except a few people for Framingham, so I'm going to give the little pre-lecture about a randomized control trial. A randomized control trial is the gold standard, and in fact, usually they say RCT, the gold standard, for developing evidence in medicine. And of course, I love the kind of new ways to describe science. Science is the process of not fooling ourselves. And if science is the process of not fooling ourselves, a randomized control trial is really the kind of dance party of not fooling yourself. I guess that's, for lack of a better way to say that. And having said that, the dance party is amazing, and randomized control trials form the basis for the science we do in healthcare. But there's limitations, and there's flaws, and there's problems with it, and I think a lot of people have ambitions to use big data and artificial intelligence to try to make some of those issues go away. Framingham Heart Study is a perfect example of something that is extremely expensive. I don't know that studies of that scale, manually done, are the things that our society chooses to afford anymore. Affording randomized controlled trials is the same thing. It's very expensive. But you guys are taking a different approach. You're doing different things. I'd like to talk to you a little bit more about that, and very specifically, if you can get all the way to this work you're doing with the EHR module, that would be amazing.
Yeah, thanks, Fred. So as you pointed out, first let me say that Merck is not just a drug manufacturer. We are a healthcare company, and we generate evidence beyond the clinical trials. So in addition to the clinical trials we run, we complement that data by using the data that we spoke about, big data, machine learning techniques, to really understand what the barriers are or treatment gaps are that may help patients manage their condition, and physicians and providers to manage their patients better. So really to understand what the issues are helps us develop interventions and solutions that may improve the lives of patients with certain conditions. I focus more on diabetes, but you can think about all aspects of cardiometabolic diseases. And most of this work we don't do at Merck. We collaborate with our customers, and our customers, for example, in the US, can be organizations like provider organizations like integrated delivery networks. They can be large national health plans. So together, we try to understand what the issues are, what patients are facing, perhaps what physicians are facing as well while managing these patients, and try to come up with a potential solution that we can test and evaluate the effectiveness in the real world of what would happen if you have such kind of an intervention. And one example, Fred, that I can provide from diabetes, which you talked about before, is EHR modules that you mentioned. And then, of course, to combine that with, Pat, what you mentioned around the guidelines. So there are guidelines from AHA, similar to the guidelines from the American Diabetes Association, for how patients should get managed when they have the condition. But many of you may know, diabetes is very prevalent, and at any given time, if you look at the US population, almost 40% of patients, or more sometimes, are not at their glycemic targets. We know that it's a very difficult condition, and there's so many different factors that may impact the glycemic control in patients. But we also know that often these patients are not getting treated adequately for the guidelines. So one of the initiatives that we have taken is we are working with Cleveland Clinic and Aetna and other organizations to really understand what the issue is in their populations with diabetes. And we have confirmed, and some of these publications are already out there, suggesting many patients could get intensified when their background therapy or whatever existing therapy is not providing them the adequate glycemic control. And these organizations that we work with are now also planning to implement a program that may reduce this, what's so-called, I would say, clinical inertia, that may help more patients to achieve goals. So coming back to the idea that there is so much data out there in the real world, it helps complement all the stuff we do in trial, which is really for the development of a drug. But to all the discussions prior, there's so much more wealth of data that needs to be, of course, interpreted appropriately, because as we all know, there are limitations of all the data we have, and we have to have the right interpretation of these data. But certainly helps to complement the information that we already have from the trials, helps develop solutions that are more meaningful for the patients and also providers who are taking care of patients with any specific condition.
So I'm going to turn on Twitter fall here. Don't make me regret that. So we will turn off Twitter fall if things get too crazy. But I'd like to have your questions start coming in through Twitter. I much prefer Twitter questions because then I can ignore the ones that are dumb questions and go just to the good stuff. That makes things easier than the microphone. So we're gonna see what you guys have to say. We're gonna start doing that. I'm gonna do one more round of interactions here, but it's very obvious this panel doesn't need me. Which is great. It's exactly what you want on a panel. Yes. What is the hashtag there? Put down the scalpel is the hashtag. I've always thought that, as we discuss personalized medicine, so much of the buzz around personalized medicine pretends evidence-based medicine doesn't exist. And I've always thought, if modern medicine, we're a mall. The escalator between the first floor and the second floor is evidence-based medicine, right? Because you've got a heart condition, you have something that is wrong. You know, if everyone is supposed to get an echocardiogram when this happens, right? If that's evidence medicine, that's the thing that takes you to getting an early detection of a congenital heart failure or something else. And so I think that people who tout at specifically conferences like this, AI, and we should do things that are really specific, underemphasize the things that we should do all the time, no matter what, anyways. And I think both of you specifically mentioned that standards, evidence-based. How do those two concepts of evidence-based medicine and personalized medicine interplay?
Well, I agree with all the things you said, and it's very challenging. And you see the gap, and we've all touched on it in some simple ways, right? And you think, well, here we have the guidelines around blood pressure, and they were just updated, and now a lot more people have blood pressure, unfortunately, 75 million, and now it's technically, I think, well over 100 million. And that's just in the US. Great, there's all kinds you look around the marketplace, there's all kinds of blood pressure devices that are popping up. The traditional ones are getting more sophisticated, and the brand new ones, many on the wrist, tied to the phones, that are advertising continuous blood pressure monitoring. And yet there are no guidelines around what to do with continuous blood pressure monitoring. We don't know what to do really with all that data. There isn't a way to interpret that independent of the way we do it now. So we have a bridging opportunity for the notion of intervention. We know we need to intervene. There's an awful lot of folks with blood pressure. And we don't always know that these devices work well, and we talked about this earlier. So there's a bit of a gap here as we transition and these technologies become more accurate, cheaper, and more sophisticated, more prevalent. And the science, in essence, for lack of a better way to describe it, sort of catches up with what to do. And then the systems, and whether those be dashboards and interpretation systems or mapped back into EHR, and so available for providers and nurses to do treatment, in order for those systems to be there to catch up and interpret and deal with all this information. But I don't know, you guys may be thinking about it in a different way. That's what struck me as an example.
No, that's pretty much along the lines I would have thought of it too. But to add more to what, Pat, you were saying, so evidence-based, the guidelines are evidence-based, we know that, right? So most of the organizations that have guidelines, there's some strong evidence to suggest whatever the paradigm has been recommended by those guidelines. But we should also recognize, and even in the guidelines, specifically most of the diabetes guidelines I know of, they always say specifically tailored and targeted approach for the individual patient. That implies there are so many different factors that are different for every patient, and they need to be targeting the right therapies using a tailored approach for the patient. So I think it's not appreciated adequately, perhaps. Two patients can never be the same, depending on so many different factors. So I think that element, I would say, highlights the importance of understanding patient needs. I will give you one example of medication adherence, which we often talk about a lot, and we know it's a big issue in most of the chronic therapies. And medication adherence is not as simple as there are patients who are adherent and patients who are not adherent. It's not that simple. The same patient can be adherent to different therapies at a given time. So they will be let's say the patients with diabetes will be very adherent to their diabetes drug, but will never be taking their statin on time. Or it could be so many different complications that they are very adherent for all drugs, and some life event happens, and they just stop taking their medications. So if you think along those lines, we do not recognize these in the guidelines, and we do not probably recognize that adequately in evidence-based, right? You have to really work with the individual patient at any given time. They may have different needs. And that's a way to think about, I guess, personalized medicine as well, is to really think about what at that moment the patient needs a support for. And it's not just your provider, it could be your support and your caregiver at home as well that really need to understand how to manage and help the patients with chronic therapy, for example.
We are. So the other thing that we're doing is we're thinking more about precision medicine, which is a different concept, I think, than personalized medicine. Precision medicine is really trying to really prospectively define patient characteristics that make them more amenable to a particular treatment. So instead of talking about hypertension writ large, just by systolic blood pressure cutoff, we're trying to talk about, okay, well, systolic blood pressure combined with your lipid score, combined with this, makes you more amenable to this type of medication. So we're trying to do that more and more within development, is become much more precision in terms of how we run our trials and deliver the evidence that ultimately make up the guidelines.
Yeah, I think that makes sense. And then you also, we've been struggling with this as well, is how do you keep that going, to the idea of now we're treating in a precise way, and then you think about regimen adherence, right? And so now you're dealing to a certain extent, perhaps, with the psychographics of the equation, which is another component of this. And how do we come to grips with the idea that we often know what to do, what the patient should be doing, but not necessarily why they're doing the things they're doing, what their motivations are. And so I think there's a third or fourth component of it, which is just behavioral issues, right?
Yeah.
So.
I mean, it's something that we've been thinking about a lot as we've been really trying to shift the way that we're thinking about disease to instead thinking about preventing and intercepting it primarily, rather than treating it. And when you talk about prevention, people generally start thinking about, generalized wellness and, making sure you get enough exercise and making sure you get enough sleep and that you eat well. But we're thinking about prevention a little bit differently and saying instead, can you know upfront those diseases to which you are susceptible and know what the environmental triggers may be then? So, genotyping at birth, I think we can probably assume that will become common at some point in the future. So you're at risk for some form of heart disease, and then that because you have not managed your diet correctly, that's then become the environmental trigger. Well, what can you do then based on that information to prevent people from ever getting the disease to begin with? And really shifting away from the personalized treatments for somebody once they're already sick to instead preventing them from ever getting sick to begin with, because that's what would be the holy grail to your opening remarks, Fred, about the healthcare system, is if we could eliminate these diseases, if we weren't treating them and instead we were keeping people healthy, it not only reduces costs to the system for healthcare, but it adds so much in terms of productivity and quality of life and other things that matter to our overall GDP. And that's what I think could really just cause a fundamental shift in the way we approach human health.
So I will let you talk if you want to keep talking. Don't feel like you jump in any time. We did have an interesting question from Twitter about what your thoughts were to the Apple Heart study. And I'll have to admit that I didn't know much about it, but I can Google here while they're talking. And the Apple Heart study is a fascinating study using the Apple Watch, and it's done with Stanford, and they're looking at irregular heartbeats and trying to understand what's going on. Of course, I'm an Android user, and so I'm just fascinated by the notion that they're going to have to put, whatever the results are, they're going to have to mention the bias that they're excluding Android users. And I think that's the kind of that kind of craziness is kind of part of the modern world we live in. Do you guys have any reaction to that question? What do you think of the Apple Heart study?
I think it's fascinating. I mean, you gave it some background. So people wear a watch. The Apple Watch can monitor your heart rate and rhythm, and it can detect discrepancies in what your heart rate should be versus what your activity level is. So if your heart rate looks like it's really, really fast and you're sitting down, presuming you're not doing a panel at South by Southwest, your heart rate should be low, right? And if it detects that your heart rate is abnormally high, it would send you a notification that says, hey, maybe you should see your doctor because it looks like you maybe could have something called atrial fibrillation. So that's the concept. From a clinical trial standpoint, what's fascinating about it is that it's basically a patient-centered trial. You download an app onto your phone. You've got your Apple Watch on. You click through some consent forms like we usually do, accept, 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 and you're in a clinical trial. And that's completely different than how we run clinical trials right now. So there's a lot of really, I think, fascinating implications of this trial. You know, the results will be interesting in and of themselves, I think, from a medical standpoint, you know, and, you know, some immediate questions will be, well, how many people are going to go running off to their doctor with false positive diagnoses, and you're going to make a whole bunch of people really nervous even though they didn't have an issue. But, you know, it really is a fascinating study, I think.
And Fred, to add more to what Dave was just saying, this whole idea of wearable technology, you can imagine the amount of data that will be generated. I mean, currently, most of the data that's collected is in when the patient interacts with the healthcare system. But most of their life is outside of that part, right? So that information is not really available to providers and the physicians. So this not only increases their awareness of so many things that they would otherwise not be aware through the data that will be collected, but also, as you said, detecting certain things that otherwise get undetected and result in a clinical event which bear cost to the system as well as to the patient's lives. So it's really a fascinating field to really have wearable technology. And it's, of course, this is for our heart, but you think about sleep patterns, think about so many different things that can really add to the wealth of information that we already have. Now, of course, you have to understand there are limitations of all these technologies. Nothing is perfect. So really, it's a new field, and we all need to understand how to get the best out of it. I think that's still something that we should think about, how to do it better.
So again, I love Twitter. Someone's providing an interesting, wasn't intended, it was actually asked a couple minutes ago, so it wasn't intended as a counterpoint to what you're saying, but I think it actually is an interesting contrast. And he says, I don't think the issue is the amount of data wearables generate, which I agree. I mean, I think in terms of actual data amounts, we have AWS now, right? We can process a tremendous amount of more data than we actually have, even though it has gone up so much. Because I think it's the lack of ambition of business models, just as with genomics. Someone will be the 23andMe of wearables, create a business model around collecting the data and returning the value to patients. And that's a super interesting idea. How does a business model work for wearables in that way? I mean, because there's a gap, right? Because, and I think you were mentioning it where you talk about, this study is going to be amazing. I don't know what it means, right?
Exactly.
So there's on the one hand there's this, and on the other hand there's kind of a lack of a business model. It's not clear who would pay for this kind of processing of wearable data. How do those things meet?
Well, I mean, I'll take a stab at it, I guess, but others can join in. I mean, I think certainly as we move more to value-based care and entities go at risk, there's more of an opportunity for this kind of data, and then used in the way that we've all described to save costs and be better for the patient, better for the system. And so the business model is contained in that transition. The other way to look at it, I suppose, is more of the business model coming off of the healthcare grid to a certain extent. It's a little more of a patient, individual-centered, maybe a little more nihilistic. And you orient the data analysis and capture flipping that information back to the individual in such a way that they can take action. And the business model is the routing to services on the back end, whatever those services may be. They may be clinical services, they may be other apps, tracking, it may be food, and this is essentially a health routing system or a marketplace, and that is your business model, which again may or may not reside in the traditional clinical experience. Obviously, it will depend on the condition and what people are dealing with. So, I mean, these are the kinds of things that are possible, but the reality is, as you noted, the AWS and the IoT and the cloud-based nature of these experiences allow for rapid analysis and orientation of the individual around their health, and then activity and health exchanges to arise as a result to fulfill those needs, right? I don't know, others may feel differently about it.
I think there is a bit of there's a technical issue here, which is kind of the difference between randomized controlled trials, as you said earlier, and generating evidence for guidelines as that process exists today, versus showing that your product has value, which is a health economic or value-based proposition. I think the challenge around wearables right now is that if we want to use actigraphy, motion sensors and that kind of stuff, as an endpoint for a clinical trial, we have to do what's called validate it. So from a regulatory standpoint, we have to say, okay, a patient who moves 20% more during the day experiences fewer events, and that's a clinically meaningful change, right? So that's the regulatory framework we work within in development. And then that influences what's typically put in the guidelines. I think that model needs to mature, given how the technology has moved forward, and regulators need to have a framework where they can start considering different ways of generating evidence and consider those approaches as well, just as we're changing and just as the guidelines groups and health insurers are changing.
I think the one other thing I may add to that is that, wearables and sensors are only as good as the amount of information they actually collect about you. And I dearly love my Apple Watch, but I don't sleep in it because it drives me nuts to sleep in it. It's too big for that. And so if you're really trying to get this always on monitoring kind of perspective, we're going to have to get it to a point where these sensors are truly integrated into our daily lives, because that's when you're going to have that kind of information that allows you to genuinely say what's the outcome based on this information. And I think we are basically at the beginning edge of this revolution and what these sensors can lead to us, in much the same way as when we first were able to genotype, we didn't really know what to do with that information, and it took years for the business model to catch up and for us to figure out how we could make sense of that. And I think we're going to be in the same place with the sensors and the wearables. They're just a lot of fun right now. I mean, I'm super active and I still love seeing how active I am each day. So I wear them anyway. But the information we're getting out of them and how we apply that to true healthcare and medical care, I think there's still a little bit of a lag, and it's going to catch up over time. And the more they're truly embedded in our daily lives, the more valuable they'll be.
Yeah, and I would add, Fred, that of course I'm a researcher, so I'm not the best person to answer about business model, but I'll say that these kind of technologies, where a patient is more likely to be engaged, actually, and get more motivated to manage their disease condition, tend to have better outcomes for the patients. Mm-hmm. I wouldn't say we have empirical evidence on this, but I will say that is a trend I can see, that we need more data to show that this better engagement leads to better outcomes. So in that case, we can also demonstrate economic impact, because so many events may be avoided because patients are much more aware of their condition.
Well, to your earlier point around adherence,
Yep.
actually, there are some interventions that I think it's app-based or something like that, where you can show a substantial increase in patient adherence with medications, with reminders and so forth.
If you don't mind me changing the subject one more time, I'm going to ask you a specific question, and then
Okay.
I'd like to ask everybody else the general case of this. One of the things we talked about was, you had the intuition that something was wrong for a long, long time, and you had these interactions with physicians where you come in and say, "I've got this problem, this doesn't feel right," and we chat on the phone where I can imagine being on the physician side of that conversation and being like, "Well, you're a young, healthy, athletic person, and the person I'm going to see after you is diabetic, and the person I saw before you had a broken arm,
Yeah.
and you're just not my patient."
Yeah.
And so, for you specifically, do you have any comments or notions about just the how are we going to teach healthcare to not think in an emergent way specific to what happened to you? And of course, the general case that I'd like you guys to follow on with that is that how do you generally do that? Because it does seem like there's a cultural problem here aside from the technological and the clinical problem.
I think it's really hard, and it's actually something my parents have asked me about, because they didn't like knowing that I went 45 years before this was diagnosed. But I think there's a couple things. First of all, medicine has to generally play by the rules, not by the exceptions. And the reality is I was a huge exception. I had a very rare condition that despite being a very large defect had gone undetected for a long time. I didn't have an easily audible murmur. I was still running half marathons. I don't blame anybody for not picking it up. It would be a really hard thing to pick up. The thing that I do react to a little bit, and we talked about this, is I sometimes wonder if physicians need to think a little bit differently about athletes, because athletes in general are willing to push through things. I mean, I don't know if our willingness to deal with pain makes us athletes, or if we, stay athletes because we're able to deal with it. But you push through things and you train through things and you suck it up and you do the race even though something hurts, or you go back out for the next play on the field, even though, I used to play volleyball and I'd break a finger blocking the ball, and they'd tape it up, put you back in the game. It's just, you didn't go to the doctor, you just got your fingers taped together and you went back out for the next play. And so that's what you're used to dealing with. And so I wonder sometimes if doctors need to listen differently to athletes, because by the time you come in and you're saying something's wrong, it probably really is wrong. And I think we also know our bodies in a different way because we're used to trying to optimize our performance and get better at what we're doing. So that's one thing that I just personally wonder about a little bit, if there's a way to change that within the medical system. And the wearables may help with that, where the doctor would really believe how much you are being athletic, versus sitting on your couch, which I dearly love too, but I do like going out for a run. So.
Do you remember having a brief conversation with my dentist where he said, "How often do you floss?" And I was like, "I floss 0.89 times a day." and he was, that was not the answer. He was.
Did you get that from your wearable? Or?
I was trying to get another way. I wish that was something I didn't have.
Chip-based floss.
Well, so that's the specific case. You've got a different category of person, and you have. You have a different category of person being not treated differently. How do we teach the general case of changing the kind of emergent notions to an intervention at the right time notion?
Yeah.
I can start. And one of the buzzwords that I have been tracking is shared decision making. But I think it really has some meaning that I feel is very useful. Most of the times the interaction in the physician and patient office is so short that things have to happen at a certain pace. But to really have the patient engaged and an effort to make the patient engage in their own condition and their therapy is a way to think about how to do that better in the physician office to start with. The culture that you describe is this culture of, physicians have limited time, how do they get most out of that, right? And then of course they're waiting probably for an hour before they meet the doctor. There may be some things that can be done there by other support staff that helps the patient have a little more role in their own therapy. So that's one part of it. I think we need to really think about how to engage the patient, improving the health literacy perhaps. Anything that can engage the patient will really help. We are focused on physician to some extent in this conversation, but I think there's a role of a patient as well. That patient needs to take.
Maybe that's a mistaken assumption. The premise that I made is that we need to teach medicine how to do that. Maybe patients should lead that.
Yeah, because I think that also patients need to be empowered to really think about their own health. That actually may translate some benefit from the physician side as well.
Yeah, this is a really tricky case, right? The doctors don't have time to look at this information, probably even if you had provided it. The pattern recognition isn't going to be there in your instance. It's pretty unique. They could have just as easily seen the opposite issue, which is with athletes, sometimes the biometric readings are way off, because they're so fit, right? Yeah. And they could have just as easily said, why hasn't that happened to you, given that? So you could have seen the other extreme and seen the gap. the other part of it is you're clearly what the psychographic world would call a willful endurer. You know, I mean, another kind of person, as you say.
My parents call that stubborn, by the way.
Yeah, well, it's the same issue, right? So you think about these contributing factors. Very difficult. I do agree with some of the comments, and Dave pressed that button pretty hard earlier. Is I think the pattern recognition, the massive amounts of data, and finding enough people that were like you would have helped. And I think the other point that was made, the better sensing technologies, more in the clothing, you know, than on the wrist, which isn't the best place to get a lot of this data anyway. It's just a nice form factor. Will help, right? And anyway, it is going to take some time to get better at resolving these kinds of things. It isn't going to be because doctors have more time. That's not going to solve the problem.
Well, so that's what I was going to say. So there's a Luddite answer, which is doctors take more time with patients, which is probably not going to happen, right? And then there's a more advanced option, which is there's some way where physicians can actually see that, you know, Kat has been, you know, even though she only comes once a year, or probably, you know, over the last 5 years, she's had the same complaint, or maybe over the last 10 years, she's had the same complaint. The problem is clinical care is episodic. You show up in the office once a year, and the physician doesn't have that longitudinal view of you, other than your labs, actually. So I don't know who's commenting on the labs, other than your labs, because you can see all the labs written out. But you don't see things like complaints and all that kind of stuff in a digestible form. So you'd wonder again if some way of aggregating all of that data and displaying it for the physician at the time of the visit would have been helpful.
So we are getting low on time, and you know, I'm merely a moderator, so what I do for a day job is not terribly important. But what I do is to work to make sure that Medicare data is available, and it has been hidden for a long time, and CareSet works to make that available, both commercially and also, we'd like to think morally, by doing data journalism work. You know, I used to have ambitions to do other stuff, but it's really just Medicare for me. I don't have time to think about anything else. But I do think the issue of data being trapped is something that is another kind of profound, fundamental problem. You know, don't say Medicare, because then that's a criticism of me. But is there any other data set, just briefly, a data set, a data source that you feel like if you just had this, boy, our efforts would really be supercharged? Feel free to go in any order.
I think well, I'm going to maybe answer that question in a way that you might not have expected, but we within pharma have huge amounts of data, right? And most of it's not digestible, right? So one of the things that we've been thinking about more and more is how do we gain more insight from all of the, you know, our 25, 30 years of experience in cardiovascular medicine, right? We have tens and probably hundreds of thousands of patients treated in clinical trials in our data sets that are just not digestible because they've been collected in different forms and all that kind of stuff. So aggregating that data and making it available to others to have insight, to churn through it and to develop insights that we could potentially leverage would be hugely advantageous. It's logistically very challenging, but it would be, you know, I think very interesting.
So Fred, I may add this, like I give you an example from some other countries, like you may be familiar with the Scandinavian registries. We don't have anything like that in the US, right? In those countries, you're tracking everybody from cradle to grave. You have everything, not just their health stuff, but anything that they interact with the system in place. I wouldn't say you need all that information, and because sometimes you have more information, it causes more confusion. But at the same time, I think we are just restricting ourselves to healthcare data. But there's so much more data outside the healthcare system that needs to get integrated to really understand individual patients better. And the problem is linking all this together. Right? What is a way to link all these data? Whether it's what you purchase at a grocery store, can that be linked in some way? Maybe there are ways to do this, and there are other countries do it much better, especially some of the Nordic countries. Scandinavian countries have that kind of a system in place. So that's one example I would think about for the US. If there's a way to connect non-healthcare data to the healthcare data, that would be a huge change in the system.
I mean, I think as a starting point, if we even connected our healthcare data, that
Sure.
would be, I mean, because like if you move, like it's almost impossible to
Yeah,
get
sure.
those medical records connected. I think there's some low-hanging fruit
Yeah,
there.
absolutely.
So,
Yeah,
sure.
I mean, I agree. I think it's not one data set. It's like you think of the poly pill, right? It's a data poly. You know, it's an aggregation of all these different data points, and then aligning them at scale against other people's data, right? And that's really a combinative effect that will make a difference, and we'll have more and more of it, particularly of the non-claims data, because of all the things we talked about here. And that imbalance may be very interesting, but as the sensors and in the clothing and these things become more ubiquitous, it's going to be very exciting to learn from that information, right?
absolutely.
So I wanted to thank the panel. You guys were awesome. We are at the end. We have cool stuff coming up. I don't know if someone wanted to stand up.